Welcome to the HealthManagement.org DigiConf, New Standards of Care. Building tomorrow's healthcare system today. Dr. Pierre-Michael Meier, CEO and President of ENTSCHEIDERFABRIK, will moderate the session. Our panellists include Donna, Chief Clinical Officer, Patient Safety Movement Foundation. Peter Kapitein, President and Patient Advocate, Inspire to Live. Weissman, Radiologist, Chair, American College of Radiology Commission on Patient and Family-Centered Care. And Lino, medical student, University at Beira Interior Faculty of Health Sciences. Let us now welcome the moderator of today's DigiConf, Dr. Pierre-Michael Meier.
Yeah, thank you so much for the wonderful introduction. It's a pleasure for me to moderate this webinar on new standards of care, building tomorrow's healthcare system today. For me, it's a wonderful pleasure because my focus is on digitalization and especially digital transformation. And if we look on digital maturity measurement, patient safety is always a key. So we have to check if our digital investments and in health IT leads to positive effects. So the key question of today's session are, what does the ideal system of the future look like? Can we achieve a truly global standardized healthcare system? What are we doing right? What elements do we build on? And personalized care, what does it really entail? So I'm really looking forward to hear all the wonderful speakers. And so I hand over to the first speaker in the session. Let's Donna Prosper.
Thank you, Pierre. Thank you, Pierre. So nice to be here today. I'm Dr. Donna Prosper. I am the Chief Clinical Officer at the Patient Safety Movement Foundation. And I think that the ideal healthcare system of the future is one that is highly reliable. We've been talking about high reliability in healthcare for a long time, and we really we have done a lot of fabulous things over the last 20 years to make healthcare safer. And for those of you who have been in the healthcare space for a long time, you know that highly reliable organizations are those who can go for a really long period of time without having an error of some kind. So that brings to mind nuclear power, aviation, the oil and gas industries. And we've been trying to learn from them for many years now, but we still have quite a long way to go. So I do believe that it is possible for us to get there. I do believe that we can have as standardized of a global healthcare system in healthcare as we do in aviation. If you go to airports around the world, it's very consistent. The safety components are the same. So again, we're doing a lot of things that are right, but we need to build on those high reliability concepts. Here at the Patient Safety Movement Foundation, we believe that there are really three critical components to safe and reliable care. The first is that we have a person-centered culture of safety. And what that means is that we are concerned with the safety of everybody that goes into a healthcare organization. That's patients and families, but it's also visitors, clinicians, frontline caregivers, folks that work in the billing department, everybody we need to be concerned about the safety for, and that safety is top of mind, that there's transparency and openness, and that all of us have the opportunity to be able to speak up when we think that something is wrong. The second component that we believe will build on a highly reliable system in healthcare is having a holistic continuous improvement framework. Now, again, we've been talking about continuous improvement in healthcare for many, many years. In some organizations, they do a really good job in improving care in a specific population. But what happens very often is that after we've improved the care in one particular population, we change our focus to a different area. So for example, perhaps we were working on healthcare associated infections before, and now we've shifted to reducing patient falls or to reducing readmission rates. And so then the previous effort fails because it's not sustained over time. And the reason for that is very often the right hand doesn't know what the left hand is improving. We have different committees that are working on different things and across the entire organization, and we're not looking at improvement at the ecosystem level. We are looking at it at the microsystem level. And so that would be the second component that we need to build upon in order to become more highly reliable. And then the third component is having an effective model for sustainment. You know, very often we have education systems in healthcare within a hospital or a healthcare organization that work very separately from the quality improvement work that is happening. We have to integrate that work and make sure that we are constantly building on the improvement work that is happening by reinforcing that through our education methods. So, you know, again, I think that we can get there. I think it's going to take a lot of work on our part. At the Patient Safety Movement Foundation, we do believe that zero preventable harm and death is possible. As a matter of fact, that's our vision, that we will achieve zero preventable harm and death by 2030. But that's only going to happen if we all work together to improve this at the same time. So, you know, we believe at the Patient Safety Movement that there are three things that we're going to focus on. The first is forging relationships with people across the globe. So everybody on this call, and every professional organization, every healthcare organization, every clinician, patients, families, policymakers, we all have to join together to be able to make this happen. We also provide education for free for patients, families, clinicians, and administrators available on our website. And then the third thing that we have to do together, again, is create that public demand for high reliability in healthcare, just like we did in aviation 40, 50 years ago. So thank you again for having me here today. Very excited to hear from the other panelists.
Thank you so much, Donna. So far, I have no questions in the chat, so we will ask all the questions and have the round table discussion at the end as a podium discussion. And so now I will hand over to Peter, Kapitein. And again, Donna, thank you so much. And Peter, the floor is yours.
Well, thank you very much for the opportunity to speak on this panel, Pierre and Health Management Organization. I want to refer to two questions, actually: the ideal system and can we achieve a global system? The ideal system, is that possible? Well, everybody will say yes, and we need to cooperate and understand each other very well. The issue in this is that we know a lot more than that we implement. And it Inspired to Live, the organization that I founded 10 years ago, we called it, we do not execute what we already know. When we execute what we already know, and that is a quote, by the way, from Sir David Lane, when we do what we know, we execute what we know, we can provide patients globally much better, with much better treatments than we do so far. So the question is, why do we not execute what we already know? Well, it started in a discussion I had a couple of years ago when Gary Roden said to me, Peter, evidence is important, but not enough. And in healthcare, we focus very much on evidence, and we think that when we have delivered the evidence, that it will immediately be implemented. And I think that is one of the biggest mistakes in healthcare. We do not execute what we already know. We think that when we have proven the quality of a better treatment, for example, that it will be implemented. And that is because there are too many interests not aligned with each other, focusing on their own, patient organization focusing on their own and try to deliver better care on their own. Industry does the same, science does the same, etc., etc. Instead of, and that is what Donna also emphasized, cooperate with each other and look for the win-win situation in this, what I call the medical industrial complex. So yes, there is an ideal system possible, but we only have to take care, and that's a lot of work, to execute what we already know. Can we achieve a global system? Well, that's even more impossible than execute what we already know. Well, we see what happens at this moment. In the Western world, Europe and the Northern Americans, we have almost vaccinated everybody above 18 years and older, but we forget to vaccinate Africa. Because we are still puzzling how we can make money out of vaccinating Africa instead of thinking from the humanities perspective and vaccinate these people on our charge. But I think, yes, we can strive for a global system. Inspire to Live started working on a world campus a year and a half ago, February, March, when we connected so far 34 countries in the world to our organization. And that is what we call the World Campus. So not only Europe and the northern part of America, but also countries in Africa, Latin America, Asia. And let me give an example. When the people in Armenia are dealing with the problems that I am dealing with, they're quite happy. And that is because the standard of care in Armenia is so much lower than the standard of care here in the Netherlands. That is what we are dealing with. That is what we are facing. We have to be aware that 6.2 billion patients in the world do not have the elementary care. So if we want to think of a global system, we have to really rethink the way we implement care globally and not only think of the rich countries here in Europe and the northern parts of America. Let me give two examples. What is possible with very less means? We work on pain management in different countries, low and middle income countries. You can treat pain with a medicine called lidocaine, which is good, safe, and cheap. It costs about 10 euros per gallon. And that is how you can treat pain in many situations, not all. In certain types of breast cancer, you can treat patients with a drug called chlorambucil, and that only costs in the Netherlands 300 euros per patient per year. Instead of that, we treat these patients with a PARP inhibitor, which costs 36,000 euros per patient per year. And there is proof that it works better when you treat these patients with chlorambucil. This medicine is also available for low and middle income countries. So yes, we can do a lot more for low and middle income countries, and that is the way we're going to achieve a better situation on a global level. Now, what we started in Inspire to Live is what we call BUCS, bottom-up cancer support, which has 3 P's, so you can remember them very easily. The first P is that you should keep a normal life when you are faced with the diagnosis of cancer. I almost forgot to say our organization only deals with cancer. So you should take care of a normal way of life during the period that you are living with cancer. That is what we call performance. Your performance should stay at a normal level. Then the second P is for prevention. More than 50%, probably 60% of the cancers can be prevented without costs. Not smoking, less or no alcohol, a lot of exercise, and that is how you prevent 50 to 60% of all the cancer. So prevention is very important. And then pain, I talked about pain management. Then if you're in the situation that you suffer from pain from cancer, there are very good, safe, and cheap means to help these patients. That is what we can provide from the rich countries and take care of the low and middle income countries. I think that should be done from a humanity perspective. So that is what I want to contribute to the discussion.
Yes, Ian. Thank you so much, Peter, for your wonderful input on our session today. I have one question into the speech before we hand over to our next speaker. And so I will read the question from the chat for you. Peter, the question is, what do you think about this? Lidocaine, is this viable option?
Oh yeah, it is. Like I said, it's a good, safe and cheap medicine, and it's known globally. Everybody knows about lidocaine. Almost all the dentists in the world will use it. And why is it viable? And that is because not all, but quite a few pains are caused by inflammation, and lidocaine works on inflammation. That is kind of a second working of lidocaine, next to that it takes away the pain. Well, if you take away the inflammation, the pain will decrease, and that is what we see when we treat here off-label in the Netherlands patients with pain caused by pancreatic cancer. Because we saw that off-label, we started here in the Amsterdam Medical Center a clinical trial with 15 patients with a pancreatitis and 15 patients with pancreatic cancer, and they are treated with lidocaine. Well, these only started a couple of weeks ago with this trial, so we cannot present the results. So far, we had one patient with pancreatic cancer, get them off morphine, get them off opiates, and the difference between lidocaine and opiates is that your mind stays clear. So the quality of life during your life with cancer is much better than when you are treating the pain with opiates. So yes, this is a viable option.
Thank you so much, Peter. And more questions then at the end in the podium discussion. And before I hand over to Ian Weissman, again, thank you so much, Peter. And Ian, the floor is yours. Your microphone. Ian?
Thank you, Dr. Meier. Good morning.
Okay.
I'd like to thank Dr. Meier and HealthManagement.org for putting together this tremendous conference where we're discussing timely and important topics today. The questions to consider there are several. First, can we achieve a truly global standardized health system? Next, what does the ideal healthcare system in the future look like? What are we doing right? And finally, what elements do we build on? We have no disclosures. Well, I think the COVID-19 pandemic has demonstrated how interconnected we are across the world. Each country's success in containing the pandemic is a world success. Each person's success in their community is their community success. Each time an individual gets vaccinated, they protect themselves, they protect their community, they prevent different variants from developing. I think we've seen how important it is to encourage early and transparent disclosure of infectious disease outbreaks. Countries need to feel comfortable doing this. They need to share data quickly. We need to combine knowledge and resources across the world to develop treatments. I think we need to support global healthcare organizations. We need to support organizations like the WHO. We need to provide global support. The COVAX program, which is providing vaccines across the world, extremely important. Recently, the International Monetary Fund approved $650 billion worth of reserve funds for countries to use to help with the pandemic. We need to recognize that as of July 7th of this year, there's been over 4 million global deaths to COVID. Long COVID has over 200 symptoms. 1 in 5 people are unable to work. So it's really important that we have a unified global healthcare system as we move through the pandemic to control it, and as we're faced with other things throughout the years. In terms of what the ideal healthcare system in the future looks like, I truly believe that health is a human right. We need to eliminate health disparity. We need to build health equity. I'll give an example of a collaborative effort underway in my organization to address this. So several solutions toward achieving ideal healthcare future. I'll give several. First, I think we need to provide food and housing assistance to people. We tend to underinvest in social services like food for people, so people can live healthier lives. And then we see the downstream effects when people develop diabetes, obesity, hypertension. Then we overspend on medical care on the end. Dr. Feinberg, who's the vice president of Global Health and is formerly the president of Geisinger Health, made this a big part of his administration to make sure that patients in Geisinger had healthy food and were taken care of. And he saw the positive effects downstream that people had less morbidity. Another issue I think we need to address is we need to eliminate financial toxicity in healthcare. I don't think patients should be afraid to go to the doctor for preventive medicine. They shouldn't feel that they'll be wiped out if they need to go to the hospital. I think this has been exacerbated during the COVID-19 pandemic. There was a recent article in the New York Times where a person said that COVID killed his father, and then he was faced with $1 million in medical bills from his father's care. So this is terrible. Andrea Kitts, who's a patient advisor to the American College of Radiology, just spoke on the financial toxicity of lung cancer care. Her husband died of lung cancer. She's a huge advocate. This is a very good article on mid-page today. I've shared the reference. I think we need to address global warming and climate change. We've seen just in the past couple of weeks the terrible things that are happening in the world. Severe flooding in Europe and Germany and Belgium, Arctic temperatures of 115 degrees, heat waves throughout the normally temperate Pacific Northwest in the US and Canada, leading to hundreds of deaths. The problem is the infrastructure was designed decades ago. It's not designed to deal with this rapidly changing climate. Greta Thunberg, a famous Swedish activist, is trying to unite young people on her cause. I thought about Louise, who's speaking today, a future physician, our future, that we really need to work together quickly to I think, prevent things from getting worse. And this is an extremely serious thing that we have to all work together across the world to address. Another topic I think is important is we need to allow clinicians to speak out to address safety concerns without fear of repercussion. This is some of the excellent work that Donna is doing through the Patient Safety Movement Foundation. I think one positive piece of news is in May of this year, in the United States, the first U.S. Circuit Court of Appeals upheld a National Labor Relations Board's decision that federal labor law was violated when the employee was raising concerns. And this is a very noteworthy decision because it's actually the first decision in nearly 20 years addressing these type of things. So hopefully clinicians will feel comfortable moving forward to be able to make, as Donna said, that we have a safer place for patients, for clinicians. We need to build health equity. I mentioned this is something that's extremely important. Currently, the American College of Radiology is collaborating with Radiology International to address the disproportionately high rate of breast and cervical cancer in women in the United States. This is a collaborative grassroots effort. We're teaming up with private industry, Hologic, with advocacy group, the Black Women's Health Imperative. You can see Mary J. Blige, a very famous singer-songwriter, advocate. She says, I'm a voice to help people get informed about how mammogram can save our lives. Her aunt died of breast cancer, so everyone's voice is important, and we need to work together. Well, what are we doing right? I'll give some examples, at least for what we're doing in the American College of Radiology, to build on the patient and family-centered care movement. This is actually one of the six strategic goals of the American College of Radiology. And I think it's important to put this in perspective, where we've been, where we're moving. If we look back about 2,000 years ago, Hippocrates, who's considered the father of clinical medicine, was a strong proponent of patient and family-centered care. He said that he didn't see medicine as just a storage bin of facts and figures. He didn't pretend to be all-knowing, but what he did know is he knew his patients. He said that clinicians are, after all, only consultants to the health of others. All we can do is hope to collaborate, build a partnership, and it's a sign of a wise clinician who's willing to be a partner in the patient's care. But what happened? Well, for about 2,000 years, medicine shifted back toward a paternalistic, maternalistic model, and the clinician became like a parent, imposing the best treatment on the patient based on their own judgment. And I think this picture on the right sums up very well. If you look at the expression on this fictional character's face, this is Dr. Craig. He's a heart surgeon in a series called St. Elsewhere, portrayed by the brilliant actor William Daniels, and you can see the expression on his face. He's really not interested in listening to the patient. And I think we need to move away from that. We need to move toward collaborating with patients. So what happened? Well, evolution, history. During World War II, there was a change in maternity care due to shortages of clinicians and resources. So the new thinking in wartime became, during war, your babies is yours to care for. And this was emphasizing self-reliance, patient-clinician collaboration. So we started to kind of move back to where we wanted to be. Interestingly, the concept of patient-centered care was only introduced 50 years ago in 1969, and it wasn't until the early 80s that the concept of family-centered care came to the forefront, and this was supported by children's hospitals who saw the benefit of having patients and family members be involved in the care of their chronically ill children. In 1986, Harvey Picker, who was a true visionary, formed the Picker Institute, focused on advancing patient-centered care. The Pickering Institute collaborated with Harvard Medical School, put together a seminal pioneering report called Through the Patient's Eyes, which talked about the 8 Picker principles of patient-centered care. Around the same time, Sievert Koop, who was our Surgeon General, was also collaborating with patients, other organizations to promote patient and family-centered care. In 2001, the Institute of Medicine, which is now called the National Academy of Medicine, issued a landmark report called Crossing the Quality Chasm, where they talked about the importance of patient-centered care. And being patient-centered is actually one of the 6 fundamental domains of healthcare quality, as defined by the National Academy of Medicine. So very important. Patient and family-centered care is expanded to research. In 2010, the Patient-Centered Outcomes Research Institute was formed, PCORI, which helps people make informed decisions about their care, and it's charged with examining health outcomes, effectiveness. This is the work that Peter is doing. It inspired to Live, which is also connecting patients and researchers and clinicians to further research treatment. So very important that we're all working together across the world to help the patient to examine best practices. And I'm very excited about the way patient and family care is moving. Well, what are we doing right? I'll talk about some of the things radiology is doing. The American College of Radiology and the RSNA, Radiology Society of North America, has been promoting PFCC for at least 20 years. In 2017, they invited 6 patient advisors to join a committee, and it was based in large part by interview through these patient advisors and patients and clinicians that they formed this website called radiologyinfo.org. And this was created to empower patients to provide knowledge and education about their procedures, their questions are answered on the website. So one, moving toward the direction of, again, empowering patients. In 2009, the American College of Radiology launched the Face of Radiology campaign, putting radiology's faces in the forefront so that patients knew they could reach out to us, ask us for help, ask us if they had any questions. In 2012, the RSNA, which is the largest radiology meeting in the world, focused on patients first, #patients first on Twitter. In 2012, the RSNA launched Radiology Cares, which is the art of patient-centered practice, and actually have the Radiology Cares logo on the back of my business card. I feel very strongly about this. In 2012, ACR introduced the Imaging 3 initiative, which is transitioning medicine from volume to value, so that we're consultative, patient-centered, outcomes focused, very important. This helps with safety, as Donna was talking about, and other issues. In 2015, the American College of Radiology created a new commission on patient and family-centered care, again, helping clinicians become more patient-centered, leveraging technology, measuring quality and patient outcomes. The patient and family care, like Donna's organization, we are tasked with building external relationships. So we're building external relationships across the world to improve patient-centered outcomes. Other resources that have been developed to build on PFCC. Well, RSNA developed a patient-centered care reading list. The American College of Radiology, we developed a patient and family-centered care toolkit, which is specific toward institutions. So if you work for VA or an academic institution or Children's Hospital, we have resources specific for your institution. This is a free resource. And if you have ideas that you'd like to share, please submit them. Again, this is a free website. It's a community effort. So please go to the ACR PFCC Toolkit. The ACR recently developed a communication curriculum to teach residents to be more patient and family-centered care, to let them understand how important this is. ACR has developed Imaging 3.0 case studies. We talked about Imaging 3.0 to spotlight radiologists who are using these Imaging 3 techniques in their practice to provide increased value. So I submitted a case study called Hello Rounds, where when I'm walking through the department and I see a patient in the hallway, I say hello. I want patients to remember we know they're there. We're there to take care of them. We bring them back into the moment. I'm there to answer questions. So all these things one can do to increase value in one's practice. The Journal of American College of Radiology is publishing appropriateness criteria, which talks about the most appropriate imaging studies for a condition. And they've asked patients to summarize recommendations for other patients. So it's patient friendly. So again, we're empowering patients to more fully participate in their care. Well, how can one help? How can one build on PFCC, the ideal healthcare system as I see it? Well, one can educate oneself, one's colleagues, can engage with one's patients, participate in PFC initiatives, for example, volunteer to be a patient advisor with the American College of Radiology's Commission on Patient and Family-Centered Care. I think social media is a very powerful way to connect with patients, patient advocates, health educators across the world. We exchange ideas, we support each other through a shared community. Currently, we're working on hashtag This Is Our Shot. We're promoting vaccinations through education and shared stories across the world, hashtag health equity. So finally, what does the ideal healthcare system look like? Final thoughts. Well, remember that when patients are involved in their care, patient outcomes improve. That collaboration with patients leads to powerful shared solutions. I actually see the ideal system as clinicians and patients walking hand in hand to speak to hospital leadership. I think that if we go as a team to administration, the patient is a customer. I think it's a lot more impactful when the patient's right there in the room to try to affect positive change. Remember that increased interactions with patients leads to decreased burnout for clinicians. A lot of us went to medicine to deal with patients, not with increasing administrative tasks and electronic health records. That if we can increase interactions with patients and clinicians, which is what we did, that decreases burnout, which is a big issue nowadays. And I think it's always important to remember that it's the patient who is at the center of care. Thank you very much. I'm looking forward to the discussion.
Yes, Ian, thank you so much for your wonderful speech and your slides. I have no question so far in the chat. So I would say we go further with our speakers and have questions to yours and the other presentation at the end of the 4 speakers round. Again, Ian, thank you so much for your wonderful speech and your focusing very good slides. And coming now to Luis, and I think this is the wonderful roundup. Now we have Luis as a student, and he will for sure have another focus on our topics. And so, Luis Lino, the floor is yours.
Thank you very much. I would like to greet the moderator, the members of the panel, as well as all the members in the audience. My name is Luis Lino. I'm a medical student at Faculty of Health Sciences, University of Beira in Portugal. First, I would like to thank you for the invitation to participate in this DigiConf. As a medical student and as a future physician who hopes to practice during the next 30 to 40 years, it is wonderful to be able to contribute and learn from this experience. And I hope that you find the ideas that Professor Henrique Martins and I developed regarding clinical practice and technology to be interesting. Medical history taking has been a pillar of clinical practice for many centuries. Even now, it is still important to provide a correct diagnosis. But history taking has remained mostly reliant on information provided by the patient and or by the next of kin. With the increase in life expectancy, populations have more complex and chronic diseases, which are often associated with conditions such as dementia or age-associated progressive memory loss, which may significantly hamper the capacity for information recall and reporting. Digital tools in clinical practice mean new tools for physicians to provide care. One such is the possibility to gather and store information related with caregiving in online and interoperable systems. As anamnesis means a patient account of medical history, the process of medical history taking using digital means would be designated a digital anamnesis. Having a clear concept and a basic model for this is very important, as it serves to guide current clinical practice and education. I invite all of the audience to read the issue that we wrote, Digital Anamnesis, Integrating Classical History Taking with Digital Health, for further details. But the key message is that the model that we developed stems from the interconnection of 3 major components: the content of the medical history to be explored via digital tools, the skill set needed for data exploration, and the interface and tools used. User experience and interface influence the physician's ability to quickly access information. Adequate template design can allow for intuitive data input and extraction. Medical specialty and setting of care should influence software design and architecture, team communication and system interoperability, increase information available, and improve digital medical history accuracy. It also provides information from different types of care, from nutritionist to nursing to medical information. Providers can then gather data to induce an holistic approach to caregiving, increasing patient safety and satisfaction, as well as quality of care, focusing on a patient-centered caregiving. Future work is needed to evaluate possible models and templates of digital and classical anamnesis hybridization. Those can be implemented in clinical practice and medical education, such as the room we have in UB Medical School for simulations. Medical educators should integrate this concept in students' curriculum, as future physicians will still most likely continue to rely on different digital tools to develop their care and their practice. Furthermore, multiple associations, such as the Association of American Medical Colleges, have advocated that digital tool skills are necessary for junior interns. Digital tools developers may integrate this information during system development stages, where priority to user friendliness and data management and security can be a point of focus. Thank you very much for having me here today.
Yeah, thank you so much, Louis, and for your insights, and thank you also for your professor and the insights you gave to us today. I have a point for Ian Weissman now in the chat. And I will start the discussion with, for sure, first, congratulations to your wonderful speech, and then you discussed radiology. How transferable are these projects among other disciplines? What a pleasure for us if you can answer this question, Ian.
Thank you, Dr. Meier. Yes, that's an excellent question. I think a lot of the work in radiology is based on fundamental principles in patient and family-centered care. A lot of the work with the National Academy of Medicine, other organizations. So a lot of the work that we've done is based on these fundamental principles. And I think it's translatable into any discipline. You can go on the American College of Radiology Patient and Family-Centered Care Toolkit. A lot of the articles can be applied to different modalities, whether one's a surgeon or dermatologist or primary care or a nurse or a respiratory technologist. So the principles will apply. They will move over because they're based again on fundamental principles of patient and family-centered care. But that's an excellent question. Thank you.
Okay, thank you so much. Now we come to another point. Thank you, Sherry. Yes, I believe most of these initiatives should transfer over well to other disciplines. Many fundamental principles. Does someone of you like to answer on this question?
I think it's just an extension of what we're discussing, that these principles in patient and family care will translate to other disciplines. So I think, yeah, it's just an extension of what we discussed. Thank you.
And then we have another extension. And the extension is, what time frame do you expect to put the patient's quality and optimized outcome to the forefront of healthcare delivery? What time frame? It's a difficult question.
Donna, what do you think?
Yeah. Well, for the patient safety movement, we think we can do it by 2030. So
that's excellent.
9 years. I think, this requires a significant culture change. I think, Ian, you said it really well when you talked about the paternalism that exists in healthcare. We do have a very paternalistic, maternalistic system, and we have to make that shift to a patient and family-centered system. So, we all know that it takes many years to change that culture, but that doesn't mean that we shouldn't start today and start trying right now.
What do you think, Peter? Yeah, that's right. I was just ask Peter, what do you think? Because you're doing this actively as a patient advocate.
Yeah, exactly. I think I have something to contribute to the discussion on this part. Another initiative that we took is Open Source Pharma, which is focused on personalized medicine, and that describes exactly what is the problem that we are dealing with. We think that we should move from drug-centric towards patient-centric, and so far everybody agrees. Everybody said, yes, of course it should be patient-centric, but if you really dive into it, you see that nothing is really patient-centric. What is drug-centric? Drug-centric is, hey, here we have a medicine and let's look for a group of patients that fit for this medicine. Patient-centric is, hey, here is a patient and with her DNA defect in this situation at this moment, we need that treatment. That's personalized medicine. So far, everybody says, hey, yeah, let's do that. That's good. Let's do that. So now the example of Chlorambazil that I gave in my first presentation. That is prescribed off-label every now and then, not many times, but every now and then by one of the best breast cancer oncologists here in the Netherlands, here in Europe. So she says this is better than olaparib in the situation of this type of breast cancer. But she cannot find funding for a trial to prove that. So we cannot get that into the protocol. And if it's not in the protocol, it will not be prescribed here in the Netherlands and in most Western countries. So we're dealing with a situation that we say, hey, this is a better medicine. This is better for patients, not only in the Netherlands, not only in Europe. This is good for patients all around the globe, but we cannot get it into a protocol. Now, how do you deal with that? It's my opinion, and Donna, in your introduction, you also mentioned that cooperation. And everybody said, yeah, cooperation. But if you bring together all the stakeholders in the medical industrial complex, which are patient organization, industry, researchers, physicians, government, and the payers, quite often health insurance companies, but let's call them payers, all the big stakeholders in it. And if you are at the table and discussing this and ask that question, why shouldn't we do what is really in the patient's, for the patient's benefit? And you explain and you look for the win-win situation. You have to be aware that the interest of industry is dictated by shareholders. So don't think you can change that part of the whole equation, but deal with it and find solutions that when cooperate, you can satisfy all the stakeholders, but put the patient at the first place. And I think that is possible. So never go alone for changing the way we work. I call it the way we work, and because I like it more than simply say that is the system, because the system doesn't have a phone number, so you can't call the system. No, but if you say this is the way we work, there is the word we in it, and we means we are responsible for the situation that we have to solve.
That's excellent. Yeah, excellent. I think I read from Donna. I think, Donna, you said something once. I read some of your articles, and it's about me in medicine, me, because we all train, and it's about me as we kind of go through our training. But if you turn the M upside down, it becomes we, and we need to focus on we as a community. So spot on, Peter. Yeah.
There is a beautiful example. Let me give an example, not from the Cancer Society, but from the AIDS Society. It was 1996 that the combination therapy was discovered. In that situation, Dr. Joep Lange, a close friend of mine, went to the Ministry of Health here in the Netherlands, and Joep was accompanied by 6 AIDS patients. At that moment, that combination therapy was not in the protocol, so it was not allowed to give that to patients. So he stepped into the office, and that Minister of Health, and that is of great importance, was the Minister of Health who knew what she was talking about because she was a physician. Joep Lange said to her, well, Els, dear Els, he always calls his Els, and he said, we have the combination therapy, but we are not allowed to give this therapy because of your department. But these 6 patients are dead in 3 months. Now, what are you going to do? 1996. And Els Borst, that Minister of Health, said, well, Joep, we are not going to let them die. You are going to treat them, and I will take care of it in my department. And her explanation for that was, when science says this is the way it is, and of course, science will never say this is the way it is because science is full of doubt, but let's say science says this is the way it probably is. And the physicians say, this is how we can treat our patients. And the patient said, this is how we want to be treated. Who am I not to facilitate this?
Yeah.
I think that is what I call in my first statement, the cooperation that we need. Do your work, good science, do your work, good treatment, and ask for your right to be treated that way by patients.
Excellent.
Mhm. Yeah, thank you, Peter. I also have here some remarks and also questions, which also belongs to this. This combination I like is, what do we need to make a system that works for everyone? Healthcare system, patients, industry, that could be transferable globally. And who should be the leader on this? Government, researchers? From my point of view, you show that this is teamwork at the end, yeah. And but I give it to our panelists. I think for this you need a national roundtable like we have here in the video conference, but let me know your opinion.
What do you think, Luis? What do you think about that? Any thoughts on that? I mean, you're starting out in medicine now. You're the future of us, basically.
I can provide a perspective on medical education. At least I believe that nowadays we are much more aware of the national and global implication of health and its thoughts on medical education regarding, for instance, patient care, patient-centered caregiving, that at least in Portugal, we can hear people say that nowadays doctors that leave the universities and colleges are much more focused on the patient and on the holistic aspect of health than on a more paternalistic or disease-focused guide. And I do believe that that is the most I can contribute to that perspective. But I do feel that in the future, I hope to contribute a lot more and be a focus or be a component on this system transferability and interoperability.
Yeah, it's wonderful your colleagues are talking about this. I think it's a new generation. I think the new generation, your age and people younger than you, tend to be more teams focused, more collaborative, which is a huge benefit, I think, to medicine in general moving forward and for the patient. So I think that's fantastic.
I'd like to add to that, Pierre, as well. I think there are a couple of things that we need in order to be able to achieve this system that works for everyone. I think the first thing is we need transparency of data in healthcare. I mean, there's a lot of talk about how many people die because of medical errors, how many people are harmed because of medical errors every year. Nobody really knows what that number is because we don't count it. So it's not a requirement for people to report it. So I think that's the first thing that we have to do is figure out how we're going to have transparency around that data. The second is we've got to align our payment systems and our incentives for delivering patient and family-centered care. There is currently not an incentive for providers to include the patient and the family in their care. The incentive is in the number of procedures that they do. So that work has to be done. And of course, that is going to be dependent on each country. But then the third is that there is no appropriate regional oversight of healthcare and whether or not we are doing a good job. The UK and Norway do each have some semblance of a regional oversight that is similar to like the Federal Aviation Administration or something along those lines in healthcare, but most countries don't have that. So I think the question I think was who should be the leader on this? I don't know that there is one particular leader, but governments have got to get involved in this in order for us to truly get to the place where we can provide patient-centered care that is truly safe.
Yeah, when I hear the discussion, it's close to this discussion we have in Germany, but when it comes to digitalization and also digital transformation, we put this year $4.3 billion in our hospitals to digitize in. And for sure, we also will have digital maturity measurement this year and in 23. And for me, the crucial issue is how I measure how digital the hospitals will be. And then I will build, or I like to build the bridge to you, Donna, and what you say transparency, and when you say data, and when it comes to the patient. And so I think this must be the forefront where we have to check, does the billions of euros really helps the patient to inform him, to collaborate with the caretaker team, to collaborate with the doctors. And I think there must be the point where we take a look on, does the money really help the patient, or does the money go somewhere?
Yeah, excellent points, Pierre. And I think to build on the person who asked the question, it's got to be considered effort, as Donna was saying. It's got to be government, it's got to be organizations. The good news is a lot of organizations are moving toward a high reliability organization, which is that we disclose our errors. For some reason in medicine, we still don't feel comfortable disclosing our errors. There are reasons for that, but if we take a look at different fields like the aeronautics industry, engineering, people want to know when they've made mistakes. They build on that. But in medicine, we're just not quite there yet. We're still not transparent enough. But with this high reliability organization framework, I hope it empowers clinicians to speak out and to feel more comfortable sharing their errors, because that's the only way we're going to improve things and decrease patient safety errors, as Donna's organization is focusing on. Thanks.
If I may just add such, one of my research interests is in electronic health records and more efficient, more focused on data management and quality. And it's a factor that in this triad of doctor, physician, patient, and technology, because it's no longer a dual relationship between doctor and patient. There is now a third component, the technology that is used in caregiving, and that equates on the data transparency, because the rights of the electronic health record, the data that the doctor inputs on the system, it is owned by the patient, not by the doctor. And sometimes doctors use technology as a barrier and not as an additional component in medical caregiving, not allowing the patient to see the screen, for example. When patients could be empowered and could be more driven to be included in their caregiving and their own health, if they would be able to see and interact with the system also.
Yeah, that's an excellent point, Luis. And I'm actually seeing some of my colleagues start to do that. In addition to having the electronic health record for the patient's chart be available for the patient to review, the question is, how do we make it easier for the patient to understand what's in the chart, right? Because we still use technical terms. but I have colleagues who are using pictures to kind of explain things, to translate into more lay language. Some of the things I spoke about in my presentation is having patients translate information for other patients. Okay, because you're right, it doesn't help the patient to have access to their chart if they don't understand what's in the chart, right? So what you're doing is very important.
Yes, and I think this is a very good point. Ian, when in Germany we have that startup who win a national prize just for translation doctor's letters to the patients, that the patient really understand what's written in, and also what helps us for capitation, what I have to do to avoid something. Yeah, I think this is also very important. And what I also see, and I hear it in your words, is what we heard when it comes to data, when it comes to population health, yeah, when it comes to regional care groups, yeah, that I can take a look on a region, how the indications, for example, what Peter explained, that you can build on peer groups and look on that. I think this we only get done if we collaborate instantly, and if we have all the data and that we can really measure. Donna, do you want to add something?
I agree 100%. And I think, you think about our electronic health records, they're not patient-centered. There's a doctor's care plan, a nurse's care plan, a physical therapist care plan, but nowhere in the electronic health record is there one place that says, here's everything that's wrong with this patient, and here's everything that we're doing about it. So, I think there was a question also that someone had asked about artificial intelligence. What a great way for us to be able to use AI. Let's go into the systems that we already have, extract all of that data from all of those different pages everywhere, and put it together in common language that everybody can understand to say, here's what's wrong with you and what we need to do about it. And to your point here, what you can do to avoid getting sicker, or to have a, and address the potential problems as well as the actual problems.
Mm. There's another question for you, Donna, out of the chat. I will read it for you from a person perspective. Is there a perfect system that can give them access to their information and appointments, but still can be human and adaptable?
That's a great question. Is there a perfect system today? No. Is it possible that we can get to that place? Yes, I do believe so. But it's going to take, it's going to take a lot of rethinking about the way that we do things today. I do think that healthcare, that technology is going to play a role in that, and artificial intelligence is going to play a role in that.
Peter, I think you want to add something.
Yeah, well, I wanted to add something to the discussion before, but it links also to what Donna says, and it's got to do with the question: how can we inform patient better? How can we get them in a better position that they can understand the electronic records? One of maybe the biggest example for our organization is ACT UP, the AIDS movement of the 90s, and so. What, in my opinion, it should be both ways. Yes, the electronic record, patient's record, should be in a language that patients understand, but there should also be a group of patients who understand everything a physician or a researcher or an industry, etc., is talking about. Because then, if you're on an equal base discussing with them, you can say, hey, you can do your work much better in a way that it benefits patients, and it can only benefit patients if you can explain it in simple words. So I think it should be both ways. Yes, we should make it easier to understand for patient what's in the electronic patient record, and we should have patient advocates who can deal at the same level as researchers, physicians, industry, government, etc., to discuss the way they work. both ways.
Yes, I completely agree. Luis, do you like to add something?
I'm sorry, but this time I'm not able to add much more to the discussion. It was wonderful, though.
Okay. Ian?
Yeah, I think the only thing I would add is it's very important for the patient to be in the collaborative work group as we figure out how to answer these questions. As Sherry asked, she pointed out something that maybe clinicians may not necessarily think about because we're on a different, maybe not thinking in the same way. So it's very important that as we move forward, that we're collaborating with patients, with patient clinician advisory committees, and that patients are telling us what's important to them. And then, as Donna mentioned, we leverage AI to help design programs to answer these questions, to make it easy for the clinicians so they can be still efficient and still have time to interact with the patient. So again, collaborate with patients, I think, is the key. Thanks.
Thanks, Ian.
Sherry has a question for me. I already read it, and I can elaborate a little bit on that, because one thing we are excellent in the Netherlands, and that is give other people the idea that we are very progressive and do the right thing. Well, I don't think I think we're doing a bit of a good job, but it's far from perfect, and we can do much better than we do so far. Yeah, there is a shift. I was becoming a patient in 2005, and I was lucky. I had one of the best physicians you could think of. More or less, I'm still in love with her. But from that moment, I saw what happens in hospital, and I saw patients who completely not understood what they were, what the treatment was, and still there is quite a portion of physicians who simply do not understand the way patients think. And there is a beautiful movie on YouTube. It is Dutch, but there is no wording in it, but it's called From God to Guide. And that's a physician in the Netherlands who is dealing with Parkinson's patients. His name is Bas Bloem, and he is really doing a good job. So he is from God to Guide. And the first situation is when he is God to the patient. He is playing with the patient, and the second moving is when he is the real guide. And it's quite of a characterization of the situation, so it's exaggerated. But I think that is what we need, from God to guide. And that movement, yeah, it starts, but I do not dare to say that we are ahead in Europe. Maybe we're a little bit, but not very much. No, we can do better.
One question from my point. We had we had the point in the chat, and to you also, Peter, that most of the people think that you in the Netherlands are very progressive, but for sure not in every point. But I think we have in all of the countries all over the world a lot of best practices, what we can share. And I think with the pandemic, we all see that there is a need for a World Health Organization. But we also see that when it comes to there is a library of best practices or something like that. And let's say also transparency of was tried, what was good, was what not good, was this helpful, was not. Do you think that a library of best practices, which is not also accessible for, let's say, academics, also for patients, will be helpful?
Yes, I think so. And best practices. In my introduction, I was talking about our World Campus. We have now 34 countries, and we come together every last Wednesday of the month. 3 p.m. Central European time. And that's not because I'm in Amsterdam and that's comfortable me, but the guy in Melbourne is 11 o'clock in the evening and the woman in San Francisco is 6 o'clock in the morning. So that fits in the time schedule. And we are coming together virtually every last Wednesday of the month. And we discuss these kind of things. Hey, this is my situation. This is the problem that I'm dealing with, and who can help? And this is 1.5 to 2 hour sessions. And immediately after we start working together in groups of 2, 3 people, sometimes 5, 6 people who work out a topic for, well, we're now working out a topic for cervical cancer. We're working out a topic for registries, cancer registries. Here in the Netherlands, we have one of the oldest and best cancer registries. So we can bring that knowledge to, for example, Armenia. And we helped with our knowledge here in the Netherlands, the people from Armenia, to set up a grant proposal for the Bloomberg grant for registry. Of course, we hope that it will be granted, but that is how you can deal with best practices. And in that situation, we now closely cooperate with the World Health Organization, with IARC, which is the International Association for Research on Cancer. So in our cervical cancer, our breast cancer prevention and registries group is a representative of the World Health Organization, IARC, working closely together with the people from, well, all these 34 countries, and we're working on more because in 2 or 3 years, we want all the 175 countries to be part of the World Congress, of course.
Yes, and here at the Patient Safety Movement Foundation, we do very similar work to what, Peter, what you're doing. And, you know, I'd love to know more about that group and what you're doing so that we can potentially link on our website to your work. Because we have what we call actionable patient safety solutions, or apps for short. And we do exactly what Peter and his team are doing. We're going out and looking for the best practices that are out there and trying to summarize them in one place so that everybody doesn't have to recreate the wheel. So, you know, we don't have the detailed oncology topics that you might have, Peter. So, you know, again, love to be able to collaborate with you on that. But I think organizations like ours need to be able to do that. That's how we can really help, so that we don't have, you know, millions of people across the world all trying to do the same thing. We can summarize it for you and say, here you go.
Ian?
Yeah, no, we have similar things in radiology. We have the appropriateness criteria where experts within the field take a look at the most appropriate test for a particular condition. As I mentioned, we're having patients now translate this information for other patients to empower patients now to read on a certain topic. So if they have this particular condition, they can see what is the most appropriate test. More globally, we have the Choosing Wisely initiative, where different specialty societies in medicine and surgery, radiology, they put forth their criteria as to what they think are the most appropriate tests, the best things to do for certain things. So similar things, what Peter's doing and what Donna's speaking as well, and it's very important. Thanks.
Thank you, Ian. And last but not least, it's up to Louis to add something. And there are also questions in the chat. I hope you see it. And so I would love to have feedback on the discussion we had and the question in the chat. Thank you, Louis.
Regarding the discussion that was conducted here, it was wonderful, and I do believe that in Portugal, and more precisely during medical curriculum and medical education, there is an enormous effort of communication with different universities and different countries in order to try to establish a minimum or a more adequate guideline to clinical practice and communication with patients and between different teams. Regarding the question in chat, it was regarding the modernization of medical history taking and how it could be conducted. In this paper, we developed digital analysis as a separate and different component of medical history taking, comparing to classical analysis, as the information is purely brought to the doctor through digital means. However, in clinical practice, that is not readily available, as patients are directly in front of the doctor. As such, we do believe that hybridization between classic and digital would be a big increase in patient care. Modernization of our clinical practice could be conducted first in medical education, inserting digital analysis and hybridization in medical curriculum so that students could be more aware of the difficulties and more prepared for clinical practice while interacting both with the patient and with the system that is in place, so that everyone can be together and can work together to the goal that is the outcome of the patient in caregiving. In clinical practice, online courses or guidelines inserting directly in the electronic health record to guide the physician during their medical history taking could be some answers that do not require a lot of effort and could really differentiate the care given to the patient.
Yes, thank you so much, Louis. I think it's now up to me to find some closing words, but last but not least, I like to close this webinar with a short answer on my or statement on my final closing. For me, this session was really fantastic. While we all doing this for the patient, and so if we're talking about patient-centric care, yeah, and if we talk about digitalization and machine learning and big data and all the fancy stuff, yeah. At the end, it has to help the patient, yeah. And in Germany, we have a small and easy sentence, and the sentence is, wer heilt hat recht. So this means in English, if you heal, you are right. If not, you're not right. Yeah. So this is a point, and then for me shows this session that we need more of this, that we need more best practice sharing, and that we need more collaboration, and that we need more data on national level and on federal level or regional level, because otherwise we can not learn so good as other industries. Sorry for saying industries, but at the end, if we're doing something like digital maturity measurement, we also have to compare us with other systems, other sectors, and at the end, this is the industry. And our customer is a patient, and that must be in our minds, independent if you're studying informatics, if you're studying medicines, or if you study business economics, or if you're studying care or engineering. The patient is up. So this was my closing words, and I would finally like to close this session with final words, and let's go on the row we have. Please, Donna, then Peter, then Ian, and then Lino. And from my side, thank you so much. See you next time, and goodbye.
Yes, thank you. No, I just want to reiterate that we're not going to fix this problem by ourselves here at the Patient Safety Movement Foundation. We need to do this together. So I invite everybody in the audience, everybody here on the panel, to join with us, join the movement, and help us get to zero by 2030.
Yeah, tremendous. I echo everyone's responses. I think as long as we're moving in this direction, patient and clinician together, hand in hand, we're going to be in good shape. And we just always have to remember that it's the patient that's at the center of care. So thank you very much. It was a real pleasure.
Thank you very much. It was a pleasure. And I do believe that The keywords here is cooperation and collaboration, as so many of you have said it already. It was a recurring topic for the patient care and for the patient care living.
Okay.
Now you can play the music, Christian.